What is orthopedic assessment? Let's begin with our introduction. Orthopedic assessment, as we know it now, started around the 1920s, and it all began with a person by the name of James Syriax, Dr. James Syriax. James Syriax was an orthopedic surgeon, a British orthopedic surgeon, and he spent a lot of his time doing philanthropic journeys to Africa. And as a surgeon, he found that access to diagnostic imaging, which he would have liked to figure out if there was, say, a ligament sprain or if it was tendonitis, he couldn't get it in Africa. In fact, it was hard to get even in the UK at the time. So he eventually realized that through following a systematic approach to assessment, you can identify with a very high degree of precision exactly which tissues are dysfunctional. And that's the birth of orthopedic assessment. So we might think that prior to this, people were doing special tests and moving the body in specific motions to identify exactly what was dysfunctional, but that's actually not the case. What happened prior to that was a lot of assumption. You have a sore shoulder, well, one time in the past somebody had a sore shoulder and here's what I did to fix it. So it's quite a new form of study, orthopedic assessment. Now, an important part is that within this, we are going to be working on tendinosis, ligament sprains, capsulitis. That really is the majority of what we study. Soft tissue dysfunctions. Everything we focus on is soft tissue dysfunctions, which is important because as massage therapists, that's what we work on. Now, when we talk about soft tissue dysfunctions, one of these I want to be very specific with, and that's capsulitis, that's joints. We oftentimes think of soft tissue as muscles, maybe tendons, and potentially ligaments. But we don't consider the fact that soft tissues or connective tissues is basically every form of tissue in the body except for bones. So we do work a lot with joints, and understanding that joint dysfunctions are at the root of many of these other pathologies goes a long way to helping you fix these problems. So now, as we go through this, these terms are almost certainly going to be on your midterm. Understanding that orthopedic assessment is a systematic, sequential process of gathering information. It's systematic and sequential. That is probably the most important thing to remember about orthopedic assessment. In the world of massage therapy, it's kind of like, go with the flow, and see what your hands do. And you don't have to have a system. In fact, if you do have a system and you follow the same procedure every single time with massage, you're probably going to be ineffective because every body is different. But when it comes to orthopedic assessment, same process every single time. That systematic process is what allows you to understand minor differences between one case and another. It's sequential. We follow the steps, and it is step 1, step 2, step 3. I was talking with Sammy just yesterday, explaining that this is, maybe it was Sage actually, I can't remember which one. I was talking to one of you two yesterday about this class being probably the only class that you're going to go through in your acupuncture studies, and one of the only classes in your massage therapy studies that is logical and linear. It's step by step by step, which is quite helpful. Because when it comes to exams, follow the steps, and I'll tell you what these exact steps are. So for some of you that's a relief, for others of you that might be a nightmare, but that's what orthopedic assessment is. We ask the right questions, we interpret the results of physical assessment, and we apply your knowledge of anatomy. We can come to a reasonable conclusion. Now I mentioned James Syriax. He used this to come up with a way of identifying dysfunctional tissues with a high degree of accuracy, right? And in my experience, that's the case. Is when somebody comes to me prior to getting diagnostic imaging, and I do recommend probably 50% of the time that they go talk to their doctor for imaging, orthopedic assessment can accurately identify the problems the majority of the times, if you know what you're doing. So not to say it's a replacement for diagnostic imaging, but in my experience, it's pretty accurate. And if people don't have access to diagnostic imaging, or they don't want to go and get a bunch of x-rays or a CT scan, orthopedic assessment goes a long way to identifying what's wrong. But you have to have a very strong knowledge of anatomy. You have to know the right questions to ask, and you have to know physical assessment. Those are the three fundamental skills. I will mention this in your practical classes as well, and that's before you can treat a problem, you have to know what the problem is, and it seems obvious, but it's not obvious in practice. Somebody will come to you and say, I have a sore neck. You go, okay, hop on the table and I'll massage your neck. And you're trying to fix the neck pain. Well, why would you do that? If you don't know why the neck pain is there, how do you know you're not going to make it worse? How do you know that you're not just going to fix it, make it feel better for the next 3 hours, and they're going to go home and it's going to be just as painful? Right? So when we talk about fixing a problem or us doing our best to fix a problem, you have to really know what the problem is. And that's essentially what allows us, what orthopedic assessment is what allows us to do that. Assessment is not diagnosis. In the world of massage therapy, we cannot diagnose. We can't do it. And meaning somebody comes in and you do an assessment and you've decided through your assessment that they have tennis elbow, lateral epicondylitis. On your SOAP notes, which we'll discuss in detail, you cannot write lateral epicondylitis. That's a diagnosis. You could write suspected or potential, or client has positive special test for lateral epicondylitis. I believe it might be lateral epicondylitis, but you cannot state what it is. You have to be a licensed medical professional. If you just so happen to be an acupuncturist as well, go for it. Give a diagnosis. But if you're doing that, that means you're wearing your acupuncture hat, which means you're writing your acupuncture license on the receipt, not your massage license. So for those of you who are wearing two hats, you have to make sure that you understand that essential difference. We diagnose a disease, illness, or condition through a diagnosis. Different scopes of practice, of course, is going to tell whether you can or cannot. And that's the case all over Canada and the majority of the United States. I'm not sure what it's like in other countries, but I do know Canada and the United States. Massage therapists cannot make a diagnosis. Acupuncturists certainly can. Any questions yet? Great. So what are the goals then? Of course, to determine if treatment is appropriate. That's like number one. Should I actually treat this person? Is massage therapy going to be the most effective treatment? Sometimes it's not. But they come there and they're paying you, they've booked an hour and a half of your time and you do orthopedic assessment and you're like, oh hey, you know what, you got a problem I can't fix. Why? Is that really what you're getting? Probably not. Probably not. So if treatment is appropriate is one thing. However, you're almost certainly going to give them a treatment. What you need to make sure they understand is the treatment you're going to give them for that day is not fixing the problem, because massage is not the best form of treatment for that problem. So we begin by knowing if treatment is appropriate and then what the treatment should be. What the treatment should be is not within the scope of this class. It's going to be in your treatments class. You'll learn how to identify every different condition that you're likely to see, but you're not going to learn how to treat them. I might make brief comments here and there, like, yeah, all you have to do is release the pecs and this problem goes away or something like that, but we're not going to go into detail about treatment. If you do have treatment questions, ask them, and if it's a brief answer, happy to answer. If it's a longer answer, see me on break. That sound good? Great. We understand the severity of the condition. With sprains and strains, we do need to know the severity because the treatment differs depending on the severity. Somebody comes in with a severe grade 2 strain versus a mild grade 1 strain, you will treat it totally differently. You can treat it, but how you do so, very, very different. So we need to understand severity. Are there any contraindications? Should you refer out? Are you capable and competent to treat the condition? When we get into whiplash, that's going to be a very important question to ask yourself. Whiplash is quite serious. There's a number of repercussions if whiplash is not treated properly. So if you do not feel competent and confident in your ability to treat a condition, you should probably refer them out. What tissue or tissues are involved? We'll talk about different types of tissues. We'll specify. But is this a fascial condition? Is Is it a tendon condition, ligament condition? Is it in the muscle? Is it in the capsule? Orthopedic assessment tells us exactly which tissue is involved. Not only that, is it supraspinatus? Is it supraspinatus and deltoid? Is it supraspinatus, deltoid, and levator? Is it none of the above? Again, that lets us know what the problem is. Somebody has neck pain, and they have neck pain because of a upper trap problem versus neck pain because of a supraspinous ligament sprain. Treatment, totally different. Far so good, making sense? Gives us a baseline of the condition. In the clinic downstairs, that's actually one of the most important things. Gives us a baseline. Are we improving? The longer you practice, the more you're going to know how quickly somebody should improve. But it allows us from session to session to know, are we actually making any form of progress? And this is found not only within our inquiry, which is rate your pain on a scale of 1 to 10, but also on a range of motion. You have 2 degrees today and you've got 5 degrees next week. That's an improvement. A marginal one, but an improvement nonetheless. And to understand what caused the injury, this that helps us determine home care. Something I mentioned before and I'll mention many times. Absolute best case scenario, what you do as a practitioner is worth 75% of the resolution. Meaning 25% of the resolution is what they do at home. That's best case scenario for you. More common than not, it's 50-50. What you do on the table counts for 50% of the progression, and the other 50% is what they do at home and their home care. If they have chronic neck pain and you have not done any inquiry whatsoever, they just say, my neck hurts all the time. Okay, hop on the table. Give them a massage. They get off the table and go, wow, I feel amazing. They come back next week, week after week after week. One question, what makes it worse? You know what, sitting at my desk makes it worse. Great. How about you sit at your desk a lot less? Give them stretches, give them activities to do to sit at the desk less. All of a sudden they come back next week and they go, you know what, my neck feels great. 3 weeks later they go, I don't need to see you anymore. Because of course, your goal as a massage therapist, emphasis on the therapist, is to never see your clients again. That's what you should be really trying for. To get them to be well and never have to come back. Emphasis on the therapist, that's the therapy. If you're just performing massage, somebody's coming in for relaxation, great. See them once a month, every couple of weeks, no problem. Any questions on any of this, on our goals? Okay. Now we have practical assessment. The reality is there's not enough time. There just isn't. You won't have enough time to do the assessment you want to do until you have your own practice and you set the rules. When you're starting out, that's probably not going to be the case. If what you're doing is exclusively massage therapy, you're going to work in a clinic somewhere. First clinic job you get is probably not going to be your dream job. It's very rare that's the case. When it comes to those dream jobs, the cushy ones that are giving you 65% and you can set your own hours and make your own schedule and design your own room, thereafter you've been practicing for 10 years, you might get that. But in the beginning, you get a job or you get a job, right? So the reality is you're not going to have enough time, but somebody's going to come in and say, my shoulder is killing me. I need you to fix it. And because you're not proficient at orthopedic assessment, proper assessment for the shoulder will probably take you 30 to 40 minutes. They're only in there for an hour. You want an hour massage, damn it. So what we're also going to be doing is talking about that reality. Is all talk, big talk about how it's so important to do these tests in this order, and it has to be done like this. And then you're going to get into clinic and day one you're going to go like, yeah, right. That's not how it works in real life. So practical assessment is understanding that we don't have enough time, the majority of the time, to do what we want to and what we need to do. So we're going to work towards efficiency. We're going to talk about assessing during the treatment. That's not a good option. That is not ideal. I would discourage you from doing that, but it is, again, the reality. Sometimes they've jumped on the table before you've had a chance to even ask them what brings them in today. It happens. So we'll talk about how to do that. If you, in time, you're going to develop a map of conditions and presenting symptoms. You're going to know very quickly, right? Somebody will say, I have shoulder pain. Next question you ask, what makes it worse? Brushing my hair. Next question you ask, what makes it better? Ice. Inflammatory condition. abducting the arm to the side, probably supraspinatus. So you'll get this map where you'll be able to navigate very, very quickly to the end result. It's like the first time you go to a city, right? You're on one end of the city and you're going to make your way to the other end. And you don't have a map. You just know your destination is vaguely west. You wander around all day and eventually you might get to your location. But the longer you wander around a new city, the better you know it, the faster you can get to your destination. That's kind of what we're going to be doing. I want to be clear on that map, though, is it takes years to develop a map of these conditions. And that's if you have the dedication and the desire to truly understand them. The better you know your anatomy, the easier your assessment will be. You know how important I find anatomy? Study it. Make it a hobby. Find a way to be passionate about it. Your job is anatomy. That's it. That's all you do all day is you work with people's anatomy. So really, really study it. Get to know the names of the muscles. Get to know the trajectories of ligaments. Know your anatomy incredibly well. And then we're going to break down individual skills, of course, that are going to be in order of most valuable skill to least valuable skill. Again, going in that order because sometimes you're not going to have the time to do all of the things. So as long as you've got proficiency at the most important skills, you should be all right. And depending on the goals you have set out, you may need to book extra time for an assessment. Meaning, somebody comes in and you have a discussion. What brings you in today? I have hip pain. Okay, and what would you like? What are your expectations from the treatment? That's one of the questions we ask. What are your expectations from the treatment? I would really love to be able to go for a walk with my dog without hip pain. Okay, that's no small order. It's big stuff. So what you might say is, all right, so you're here for an hour today, no problem. Hop on the table, I'm going to give you a massage. Next week, though, when you rebook, I want you to be aware that we're probably going to spend 30 minutes doing an assessment and 30 minutes doing a massage. So week 1, you just say, okay, jump on. We'll give you a massage. We'll make you feel good. But set the expectations if that's what you want to do. You might not, though. You might be like, you know what, here's a card to somebody who actually likes that stuff. I don't like doing therapy. Fine, you don't have to. Questions on that? Sounding good so far? Yeah. So some important notes then. This is not an exact science by any means. Not even diagnostic imaging is an exact science, which is why people go to school for 4 years to learn how to interpret an MRI. It's much closer to an exact science, but there's a lot of variation. So we just do our best with what we have. It's not exact. It requires practice and it requires patience with yourself. It's just like any other physical skill. Some of you have been massaging now for a couple of years. Some of you, this is your first year. And as you know, when it comes to massage, it's a long time to get comfortable with even a simple stroke up the back. Same goes here. It's going to feel awkward, it's going to feel uncomfortable, and it's going to feel like you have no idea what you're doing because it's a new skill. So be aware of that. It can be confusing. What I mean by that is somebody comes in and they say, I have shoulder pain. I'm like, okay, great, no problem. Awesome. Let's do the range of motion. Do the full range of motion. No positives, not one. Nothing comes to you. Every single special test, no positives. And you say, well, what hurts your shoulder? And they're like, every time I lift my arm to grab a cup from the cupboard. It doesn't make sense because you've just done every single thing I've taught you in class. You can't find anything. It does happen sometimes. It's really confusing. Now, if that is the case, my experience has said that it's almost certainly a fascial issue. Maybe it's a hip problem that in some weird way is distorting the mobility of the shoulder. But that being said, prepare yourself for sometimes you don't know what's going on. Keep an open mind and treat represents that day. Talk to some of you about this in clinic. You read through the previous week's files. Great. Very important. Have an idea what you're likely going to see. However, when they come in, it might be totally different. Maybe they've had hip pain, and the hip pain is presented primarily as piriformis, but for whatever reason, Now they're coming in with hip pain, but instead of piriformis syndrome, it's gluten-Mead syndrome or something like that. So it changes day to day, which means every single time you see somebody, treat them as if you are not entirely clear what's happening. Don't assume. That's last, make no assumptions. Sometimes there's no obvious answers, and we assess it based on the results of treatment. Now that's a strange one. You don't know what's going on. You have no idea. So you do a treatment. You do your best guess. Like, I think it's supraspinatus, or I think it's the joint capsule. And you treat it. They come back next week and they say, I didn't feel any different at all. Well, okay, I was wrong. If it's not that, then it's probably this. Or you guess that it's the capsule. You do your joint play, and it turns out they feel amazing. So sometimes your assessment is based on whether the treatment works or not. Good? Great. So let's talk about another important skill. This is clinical reasoning. Clinical reasoning is it's a skill that any healthcare practitioner needs, and acupuncturists don't use clinical reasoning nearly as much as massage therapists do. Acupuncturists use intuition a lot more and pattern recognition, whereas in orthopedic assessment, it's a step-by-step reasoning process. I think it's oftentimes like trying to solve a mystery. And if you like solving mysteries and solving puzzles, then orthopedic assessment is going to be a joy. It will be interesting because that's exactly what it is. You're basically a Sherlock Holmes of the body. So, what is clinical reasoning? Well, this comes right from Whitney Lowe. The practitioner's eventual success relies strongly on their development of reasoning skills. So as you go through all the physical skills you're going to practice, how to do proper range of motion, how to do proper special tests, and how to ask high quality questions, keep in mind that at the end of the day, your ability to reason through the answers is what brings you to the appropriate conclusion. So clinical reasoning is the process of using the information we have gathered to come up with a working hypothesis of what's wrong. That's what you got. You got a working hypothesis. It's a guess. It's your best guess. Sometimes your guess is really close, sometimes it's not. But your clinical reasoning is the process that takes you towards that hypothesis. It's all about probabilities. And it really is probabilities. In fact, that's what our special tests are when we get into special tests. They increase or decrease the probability that you're dealing with a specific condition. They do not confirm conditions. They just increase or decrease probability. So there's no certainties. It's all about probabilities. No absolutes. So in school, we always, like your exams, for example, your practical exam, there's going to be one answer. It's going to be obvious. It's going to follow the exact pattern that's laid out in the slides and in textbooks. And when you do read textbooks, it's like, yeah, somebody comes in and they have pain on active and resisted abduction of the shoulder, and it's a positive drop arm test. They have supraspinatus tendinosis. Come into clinic, and that's almost never the case. We might have positive, active, and resisted abduction, and positive flexion of the shoulder, and maybe positive external rotation passively for some reason. So when we do this, it's about more likely and less likely. We gather information. The more we gather, the more close we get, or the closer we get to the possible truth of what's happening. So the more information we have, the better. It's how we connect theoretical knowledge with the information from your client. Your theoretical knowledge is essentially your anatomical knowledge and your knowledge of what causes injuries. That's a good portion of what we're going to be discussing in this class, is what causes injuries, what causes adhesocapsulitis or piriformis or TOS. So here's the process. Another great midterm exam question. So first off, we begin with history, physical assessment. Next, we interpret and organize. So that's acquired, that should be data, not data, sorry. Acquired data. historical and physical assessment, you do all your questions, you essentially take as much information in as you can. If you don't have time, you have less data to work with. If you have more time, you have more data to work with. That's it. Just pure information. Next, interpret and organize. You try and make sense of the information. After that, you make a hypothesis, which includes a differential diagnosis. Your hypothesis, your clinical evaluation, it will be, I believe it is supraspinatus tendinosis. My differential diagnosis is subacromial bursitis or shoulder impingement syndrome. You should never have a one answer. You should have a most likely and next most likely. In your mind, you're always thinking it's probably this, but it could be that. And that's your differential diagnosis. You're essentially writing all the things it could be based on probability. It's most probably this. Does that part make sense? And then you test it. That's it. You test all of your different assessments, your diagnosis, what you believe it is. You can test it with special tests, which in some cases are highly accurate, in some cases are almost useless, or you can test it with treatment. But essentially, that's the process. Orthopedic assessment goes through all of this except for treatment. I apologize for that. Try it and see how it is.
Try it out.
Too dark? Better.
Yeah.
Okay. So continuing on with clinical reasoning. Based on what you believe, you can test it or trash it. That's it. So I think it's supraspinatus. I don't think it's adhesive capsulitis. If you don't think it's adhesive capsulitis, trash that idea, throw it out. A good example, lateral knee pain. Yes, lateral knee pain. I really like lateral knee pain as an example because it's simple. But lateral knee pain, there's 4 possibilities. That's it. There's only 4 possibilities. Possibilities are going to be meniscus, LCL injury, IT band injury, or ligament or capsular injury. That's it. And out of those, it's almost certainly going to be one of the 3. That's meniscus, LCL, or IT band syndrome. So if somebody comes in with lateral knee pain, you go through all of the questions, and that's going to tell you, well, this could be LCL, but maybe it's IT band syndrome. So from there, you test both of them. Whichever one is more likely, you throw the other one out as a less likely. Yeah? So we develop it, of course. Any given client may have a combination of different conditions present, and clinical reasoning helps differentiate similar conditions. In acute conditions, it's usually just one. That's it, just one product. In chronic conditions get confusing because they got into a car accident 5 years ago. They ended up damaging their anterior longitudinal ligament, which is the primary injury, which still exists. It healed long, for example. And then over the last 5 years, they've lost a cervical curvature of their spine and they've developed hypertonic scalenes. The hypertonic scalenes have compressed on the brachial plexus, which then has led to numbness, tingling, and paresthesia in their hand. But they also work an office job. And we know that if you work an office job, your likelihood of developing carpal tunnel syndrome is kind of high. Because they've already got TOS, they develop a secondary neurological compression, carpal tunnel syndrome. And all of this started because they got into a car accident, which damaged their longitudinal ligament, which tightened their scalenes, which compressed the brachial plexus, which led to double crush phenomena, which caused carpal tunnel syndrome, but they're coming in because their hands. See how the main thing that's present is going to be hand is numb, but clinical reasoning, asking the right questions, taking a good quality history, doing high quality range of motion, lets us see ultimately the root of this is that neck. Poorly evaluated conditions can result in poor or inappropriate treatment, obviously. And it's unfortunate, but don't let that upset you if that's the case. You do your best. And sometimes you don't have the time, sometimes you just haven't developed the skill, but understand that the better you are at assessment, the better you will be at treatment. Cool. How are we feeling about our introduction so far? Any questions? Seem overwhelming, pretty simple. Where are we at? Give me a tone.
Seems good. Seems like it's gonna be a lot.
Yep. It's quite a bit. It is. What's important, and I appreciate you saying that, Sage, because I want to address that. Within class, I'm never going to be hard on you because I understand that this skill takes a very, very long time. What we'll see is it is systematic, and I'm going to repeat myself every single day, probably 6 to 8 times a day. I will say the exact same process. Because then ultimately, if you know the process, anytime somebody comes in, if you do that process, eventually things start to make sense. So you don't have to memorize exact range of motion positives and negatives. It's more about the process. Okay, let's talk intake forms. We talked about this a little bit in clinic yesterday morning. Continue on. What form is best? It depends on the type of medicine you're using, of course. In massage therapy, well, all of them are going to include name. That's important. It has to be their full name, ideally their full legal name as well. Their date of birth is important. Their preferred gender identity is not as important for massage therapy, but quite important for other practitioners. It's a little bit of a sensitive issue these days, however, it's still something that should be on intake forms. Their current address. So every once in a while, it's worth checking in with your clients. Do we need to update your phone number or address on the forms? I'm sure you've been asked that a bunch of times. Keep that in mind. And their occupation, I really like this one. That actually gives us a lot of information about what could possibly be wrong. Knowing their occupation, simply knowing their occupation could tell you what the problem is, or almost certainly, more likely. And contact information, phone number, and email, one or both, up to you. I keep in contact with my clients via email, not really via phone, so that's my preference. And an emergency contact, again, that has to be on there as well. Notes, read the intake form. Seems obvious again, but it's something that you just might not do. You go out, you grab the intake form, all right, I'm with Susie, come on in. But if you read the intake form, all of the information, there's important questions on it. My current intake form, largely, almost exclusively now I'm doing acupuncture, but my massage therapy form I had, took me quite a long time to fill out. I would send it to them digitally prior to them coming to see me. Because it takes 10 to 15 minutes, which is great because that's 10 to 15 minutes of their time and my time that we can spend focusing on treatment. So they'll fill it out, I'll read it before they get there, and it saves me a ton of time of asking questions. I only have some clarifications to make instead. So read what they write down. If you have the luxury of making your own intake form, decide how much information you want. Ask simple questions that do not require a lot of detail. People won't know what details to give you. Where is the location of pain? When did it happen? And only give them like 2 lines. What happened? Don't give them a paragraph because some people will fill it. You want them to summarize as best as possible. Keep it quite short, detailed. Use diagrams. You've seen them on all of our intake forms. Circle the region of the body that's causing you discomfort. Shade it in, however they want to do it. And it's a good idea to list conditions that may affect your treatment. So on the massage therapy forms downstairs, there's only like 5 or 6 treatments, I think, like high blood pressure, cardiovascular disease, history of cancer, something like that. So on your intake forms, you don't have to have that full list of every single problem that's wrong with somebody, because for massage, it's irrelevant. It doesn't matter too terribly much. You may need your client to fill out updated, right, we've already talked about that, so update the information whenever appropriate, keep their address current. Now this is a sample form. I can give you access to this, but as a massage therapist, it's got way too much information. The more important forms will be the ones that you have downstairs. What we did talk about yesterday is every clinic is going to be different. And your clinic will probably change with time too. So there's no standard intake form. There's just the things that are on most intake forms. A consent form, we talked about this last year in ethics. We talked about it yesterday morning in class, but I'll talk about it one last time. Each profession is going to have unique consent form. So that means for those of you who are combined, massage and acupuncture, you can have one massage form and one acupuncture form, or you can have a combined form if that's how you choose to practice. But note, if you are both acupuncturist and massage therapist, if you do not put a needle in, you are practicing massage. If you put even one needle in, you are practicing acupuncture. And your clients need to be aware of that because their coverage, their insurance coverage, might not cover acupuncture or massage or something like that. So be very, very clear. Informed consent is written acknowledgement that the participant or the client understands the risks inherent in a particular activity. That's it. They just say, I understand there are risks. That's all you're doing with your consent form, is telling them the risks, telling them the benefits, and they say, I get it, I understand it. It's incredibly important to be filled out before the first session. Don't miss it. In informed consent, so somebody signing an informed consent form does not mean they cannot sue you. They still can sue. However, if they sue you for something that is on the informed consent, they're probably not going to win, so long as you've been clear about the damages and issues. I'm not going to bring up suing too often because it doesn't happen too often. It's not something you should concern yourself with, but this is one of the best protections we have. If you're going to perform any intervention that's not on your usual consent form, they should fill out a new one. So what that means is, on your informed consent form, you have not written anywhere that you are going to perform hot stone massage, for example. You just decide, hey, I'm going to do some hot stone. Is that okay with you? It's verbal consent, but because hot stone has inherent risks to it, largely burns, they should fill out another informed consent. Signing, I get it. There's possibility of burns. Keep it up to date. Anytime you learn a new technique that has inherent risks, add it to your informed consent form. Make sure they verbally agree to any treatment as well. And it doesn't have to be like official, like, do you understand that you are going to be, no, it doesn't have to be like that. You just tell them what you're going to do. Hey, I'm going to be working on your glutes now. Is that okay? I'm working on your upper chest now. I'm going to be working on your head now. And it gets a little bit redundant if you're doing a relaxation massage. Hey, I'm going to be moving into your superior back. Are you okay with that? Which is why we check in with your clients. How you doing? Everything okay? Yeah, it's fine. Great. Wonderful. Deep things and anything injurious, double check. They've already signed, it's okay to do cupping. They've already signed, it's okay to do deep tissue. Say it one more time. So I'm going to do some cupping now. This is going to likely cause some bruising on your back. Are you okay with that? I'm sure they understand what they're consenting to. I've read a case about this, that somebody came in and English was not their first language. They came into a clinic, they ended up getting quite significant bruising from deep tissue massage, and then they sued the massage therapist for not telling them. They signed the informed consent form, but they didn't understand what they were signing. They didn't read it properly. So that's part of why it's important to do verbal consent and explain verbally as well. And it is not a waiver. A waiver waives your rights to sue. So if you, that's important for yourself too. Whenever you do any sort of risky activity, you're signing a waiver versus a consent form. A waiver means you cannot sue. Consent form means you consent to treatment, but you still can't sue.
Excuse me. I have some questions. Remember, my English is not so good. First, what means waiver?
Waiver, that's a type of form. It's a waiver form, and it means I waive the right to sue. So there's consent form, meaning I consent to the treatment, and then a waiver is a different form that if you treated me and you gave me a waiver, it would mean I cannot sue you.
Okay, another one. Every time the patient comes to the clinic as to firm a consent form, or only once?
Only
the first
once.
one.
Yeah.
Okay. And the other one is if you're going to treat him with massage and acupuncture, is only one consent form, or is one for each for acupuncture and for massage separate?
That's up to you. If I'm doing massage and acupuncture, I have one form for that, and if it's just massage, I have one form for that. So it's up to you how you do that. It's easiest if you do massage and acupuncture, one form. Everything you're going to do. All the risks and benefits of massage, all the risks and benefits of acupuncture, they sign just one form.
In the same form.
Yes. If all you're doing is massage, if that's it, that's other form.
Okay. Thank you.
Yeah. Talk about soap notes. So you guys saw the soap forms downstairs. Like we talked about yesterday, they're not universal how they're laid out, but the expectations of what you write and how you write are pretty universal. So, standardized system of recording information gathered during treatment sessions. The history of soap notes is, kind of interesting, I guess. Nurses came up with soap notes because doctors would work at one hospital, nurses would shift around from hospitals, or they would be responsible for reading multiple different doctors' notes, and it just didn't make sense. So nurses came up with a standardized system of intake and inquiry. And then from there, pretty much every other medical profession has adopted them. What you'll find very interesting, acupuncture does not have soap notes. We've got charts, and it's a complete gong show. Which is strange, because of all of the different healthcare practitioners, healthcare forms, acupuncture is one of the only ones that do not use soap notes. I think we probably should, but
Can you use soap notes?
absolutely. It's just not standardized.
That's why you guys teach us soap notes for acupuncture, but it's not. We don't have to do that.
Oh, like legally you're not required to do it that way? 'Cause
Legally, you're not required by anybody to do it that way.
Right.
It's just not done.
But that's how we learn it? Is that how we learn it?
Yeah.
Okay.
But we have to do it for when if someone comes in and if there's like an issue, like we're getting sued as an acupuncturist and they go back and look at our notes, what is the requirement? Not soap notes?
Well, no, okay, what's important is soap notes is a systematic process that takes you through subjective, objective assessment plan. Whereas in TCM it's chief complaint, differential diagnosis, treatment plan, and points. Which you would call, you might call it a soap note because that's what everybody calls taking notes, but it doesn't follow the systematic approach of soap notes. So when I read the charts downstairs for acupuncture students, it's not a soap note. It's just a chart. It's a client chart, and it's standardized for what you've been taught. But go to a different place, it's not the case. Whereas, so one clinic to another with acupuncture notes, it's gong show. It's different. One clinic to another with massage therapy notes, it's systematic. The form might look different, but how it's filled out identical, which makes life so much easier. Stands for subjective, objective, assessment, and plan. That is what a soap note is. Let's talk about each one of these. Oh, for the purpose helps to organize a treatment, first and foremost. Everything as organized as possible. Helps you organize your thoughts when it is written down in the same way every single time. When you understand the process in which you go through every single time, it will help you think more clearly. Records the treatment goals, plan, and progress. It's pretty important for helping you understand and your client understand that they're making progress and knowing what the eventual goal is. And it is a legal document that can be used by third parties. I've had a number of cases, which I think I mentioned some of them in ethics last year, where it's possible that your SOAP notes are going to become evidence in a court case, particularly if we're working on people who have an MVA, motor vehicle accident. So they can be legal documents. They need to be very detailed, very precise, very clear. Acts to protect the practitioner if the patient has any concerns regarding the treatment, which is why I'm always harping on clarity. What did you do in that treatment portion? What did you do? Massage the back. Not enough. Which regions did you massage? Because if somebody comes in and says, I was touched inappropriately, somebody, the therapist massaged or touched my genitals, and you look at the SOAP notes and say, I massaged your back, I massaged your hamstrings, and I massaged your calf. That's what I worked on, very, very clearly. I wasn't even in that region. If your SOAP note is very clear, that goes a long way, a long way. Starting with subjective, this component is a detailed narrative format that describes the patient's self-report of their current status in terms of their function, disability, symptoms, and history. It's where you talk. That's it. Subjective portion is the conversation. It's where they describe to you using their own words. And you try and let them use their own words. And you'd be surprised how much information you can gather from simply paying attention to the words they use. Not trying to interpret anything, just listening to how they describe the pain, where they describe the pain. So let them use their own words. All of the answers from the history section are recorded in subjective. So when we talk about history, that's your case history. We'll separate it into different portions. Common mistakes, passing judgment on a patient. Patient is overreacting. Patient, maybe they come in and be like, oh my God, the pain is so extreme, it's a 15 out of 10. And you're just irritated and frustrated, so patient is being a pain in my ass. There we go. That's obviously not something you're going to write, although it might be true. Documenting irrelevant information. Patient complaining about previous therapist is the example I give here. Doesn't matter. If they say something that's not related to the case, they're just telling you a story about their weekend, you don't need to write what they did for their weekend. So it's not all of their words. Including opinions. Patient was willing to participate. That's an opinion. It's not your experience, it's their experience. Everything that they say. And we will talk more about this, and I'm pretty sure I have it somewhere in the slides, but I believe that the subjective portion or the history portion is probably the most important portion. When you ask questions, you know how to ask questions. You can gain a huge amount of information. That verbal communication is key. Objective. This outlines the objective results from the assessment process. This is where you include the positives within range of motion and special tests. You can also include postural assessment. Client has a forward head posture. Client has immediately rotated shoulders. Pain behaviors. Client is limping. There was a guarding posture. It's a typical AC guarding posture, it's called. We'll get into it. Client has typical AC guarding posture on right shoulder. Any of their postures. Movement and range of motion. Client has pain on resisted abduction of right shoulder. And then your special tests. We also include palpation. This is objective. I palpate heat on the right knee. Common mistakes, too little detail. Pain in shoulder during range of motion. Doesn't tell you which motion was pain. So too little detail.
When you're talking about palpation, maybe this is obvious. Like if they're saying it's like really tender, like that's subjective, objective. Like is it based off of what you're feeling, what they're saying?
Right. It's not obvious, and it's a really good question. It's often, primarily with palpation, it's what we feel. However, if they report pain on palpation, and that's an objectifying the amount of pain, that's subjective. But the fact that there is pain for them, although it's still some way a subjective thing, we would put that in the objectifying. But what I mean largely when we're palpating is we don't palpate for pain. That's not the point of our palpation. It would be, I palpate hypertonic tissues. I I palpate heat, I palpate rough skin. So it's what you experience during palpation. And that is a note I'll make many times. We don't palpate for pain. It's not really what we're looking for on palpation. We can find it, but not what we're looking for. A, assessment. By interpreting the information gathered in the subjective and objective sections, you should have a clear impression of what tissues are involved. This is your professional opinion. This is where you write down what you think it is. Suspected lateral epicondylitis. Possible frozen shoulder adhesive capsulitis. And explain the reasoning behind the decisions to clarify the support in your analytical thinking. Now that part's not necessary. The assessment portion is just, here's what I think it is. If you want to be really detailed, I believe it is lateral epicondylitis due to the presence of a positive tennis elbow test. You could explain yourself, you don't have to. Be sure not to give a diagnosis, of course, unless it's within your scope. It's where you write notes on how the client is progressing. The client is progressing significantly since last week. There is an improvement in mobility. Common mistakes. Notes on progress are too vague. Patient is improving. How are they improving? They're improving in their range of motion. They're improving in their pain levels, whatever it might be. And lastly, the plan. What you're going to do for the treatment. That's the first part. For the treatment, again, it's part of your treatment class, but you should have a plan going in. You should technically be able to fill out your SOAP notes almost completely before you walk into the treatment room. You don't, because there's no time, but that's what you're going to be doing, or what the treatment was. It's based on the information you've gathered from previous sections. You are going to come up with a plan. It may include your plan for subsequent visits. Within this, myself, I will write, next week, make sure you do this technique. Just a reminder to myself. During this part, I'll write, performed joint play on shoulder, and client really didn't like it. Don't do that next week. So notes to myself for the next couple visits. Should include notes on home care. We'll talk about detail, but perform wall angels 3 times a day, every day, whatever it might be. Common mistakes, too vague. Massaged leg, same treatment as last week. I don't like that at all. I don't like seeing it.
I remember yesterday you said you figure out how to write the notes better.
It takes time. It takes time. But that's the biggest problem in this plan section, is it's too vague. Massaged back. What I would like to see is which muscles you massaged, which techniques did you use. Right now, unless you have any other advanced training, this is simple. Perform effleurage and petrissage on the erectors of the back, the quadratus lumborum, the upper trapezius, the posterior shoulder muscles. That's it. Because within that, effleurage and petrissage include another group. I perform trigger points on the rhomboids. That's a different technique. I perform myofascial release, soft tissue release, passive stretching, the name of the techniques. For again, now, simple. Effleurage and petrissage and trigger points. That's all you've learned. Anything other than that, you start to be specific. Does that make sense? More detail is better. Notes on variations. So the most notable is what's written in the objective and assessment. The reason I say this is because this system is made for nurses, and massage therapy have kind of done our best to twist it so it works for us, is sometimes what is written in objective and assessment changes. So some write the results of range of motion in assessment because that is part of orthopedic assessment. That's not wrong, it's just not the way I teach it. So, what that is to say, where you write those two portions, the outcome of your physical assessment and how you perform the physical assessment can technically be in either objective or assessment. Again, I prefer objective because it is objective findings. The assessment is what your clinical assessment is. Cyriax, McGee, and Lowe all teach it the same way I do. It's pretty standard, but you may see it otherwise. I won't talk long about this at all because we did cover it at great length in ethics last year. It's electronic health records and electronic medical records. Almost all clinics now are online. You can find some smaller clinics that still do things with paper. Ours is a good example. The biggest reason is it's too old. It's too old to go back. Right? You've got some clients who've got a file this thick that would all have to be input manually. But many clinics are using electronic health records and electronic medical records. Many new practices are using them. Many old practices are. It saves space. Can we talk about this at great length in history? If you do so, reminder, HIPAA and PIPEDA, make sure that it is legal. Electronic health records are not Microsoft Word documents. They have to be secure and it has to follow these protocols. Great. All right, that's it for introduction level 1. Thanks for watching. Don't forget to hit that like and subscribe button. It helps our channel out a lot. If you like this type of material, check out these other videos on special tests within each region of the body, as well as some in-person recordings of me teaching orthopedic assessment theoretical concepts to a live class. If you would like to take a complete course on orthopedic assessment, check out the link in the description below and make sure to use the coupon code for a super awesome discount. In the course, we go through all of the theoretical concepts as well as how to assess every region of the body and identify many different forms of dysfunctions. All right, see you next time.